Greetings and welcome to our 25th now of our Town Hall series. It's really great to see everybody here today. I'm getting over a cold. You might hear that a little bit in my voice. My apologies. Promise you it's not COVID. I've been tested about a gajillion times for that. But it's my pleasure to welcome you here today. As always, I want to thank our Society for Leading Medicine. I'd like to thank Jeremy and Caroline Finkelstein, as well as George and Catherine Masterson for their chairmanship of that, and thank them and all of you for your support. Today we have a great topic, and we'll be talking about women's health and focusing on our women's health initiative at Houston Methodist. And we're really looking at the physical aspects and the mental health aspects of women's health, from prevention and screening all the way to some treatment and therapies and other things. And so I think you'll find today very, very interesting. As always, we have actually somebody in the background who's there to answer your questions in the chat. I want to thank Dr. Lucy Castile for being there for us to do that. So keep the questions coming. And if you'd like any questions for us to address later in our dialogue and our Q&A session, text the word DeBakey to 37607, and we'll capture those and do our best to get to all of those questions. You know, we have a wonderful group of leadership volunteers that are part of the President's Leadership Council who focus and advocate for women's health. I'll tell you in a little bit later about a wonderful recent event we had focused around women's health, and I'll show you some photos from that as well, and I want to thank all of them for helping with that. The co-chair of that is Marcy Margolis, who is here today to introduce our speakers who are here with me today. Let me turn it over to Marcy.
Good morning. I'm Marcy Margolis, co-chair of the Houston Methodist Women's Health Task Force. The Women's Health Task Force is a newly formed group of volunteers who work with the talented physicians within the Women's Health Services and the Houston Methodist Foundation to raise the visibility and awareness of the exceptional programs and specialties that impact women at every stage of life. We are excited to be a part of today's town hall, and we welcome you to the program. Today, we will hear from Dr. Danielle Antosh, Interim Chair of the Department of Obstetrics and Gynecology and Director of the Center for Restorative Pelvic Medicine. In her talk today, she will give us an overview of the department and discuss the latest advances of pelvic health. We will also hear from Dr. Kathleen Borchardt, who will discuss updates in obstetrics and cancer screenings. And finally, Dr. Jessica Rohr will talk about a very important topic, women and mental health. I'd like to give a big thank you to the Houston Methodist leadership, physicians, and scientists for all they have done and continue to do to lead medicine. As a reminder, we are in the early stages of planning for our Women's Health Symposium for 2023. We hope you will consider joining us in supporting the amazing efforts of Women's Health Services. With that, we'll turn it over to Dr. Danielle Antosh.
Hello, good morning, everyone. I'm very thrilled to be here today in support of this town hall talking about women's health. Many of you may not know it's Women's Health Month nationally, so I'm just very excited to talk about some of the special things we're doing here at Houston Methodist and also give a department update. So our vision of the Obstetrics and Gynecology Department here at Houston Methodist really focuses on delivering comprehensive and outstanding health care for women. We really offer a compassionate approach to both wellness and illness, and we provide women's health services through a multidisciplinary collaboration within world-class facilities and an academic environment of research and learning. So here's just an overview of our department leadership. I'm currently the interim chair. Dr. Meredith Morgan is the elected deputy chair. Dr. Patricia Bellows is the division director of the General OB-GYN division, and Dr. Aparna Kamat is the division director of gynecologic oncology. Dr. Harms is our OB-GYN residency director, and Dr. Stafford, our neonatal director. We've had tremendous growth in our department, both in our surgical volume and our obstetrical services. We also have some growth in our faculty. And as you can see here, we have recent additions in the last 6 months to Houston Methodist Woodlands Hospital with Dr. Zand, who specializes in gynecologic oncology, and Dr. Rogers, who's general OB-GYN. Dr. Erin Manning joined us last September in our department here at Houston Methodist Hospital, and she specializes in gynecology and menopause medicine. And then we have two new additions that'll be starting in faculty that'll be starting in September. Dr. Emily Rutledge is specializing in urogynecology, both at Houston Methodist Clear Lake and in the medical center. And Dr. Rachel High will be both in Houston Methodist West Hospital and the medical center. And so we're really excited for them to be starting with us. You know, our department really has covers a broad range of subspecialties within OB-GYN. I know Dr. Bohart will be talking a little bit more about our obstetrics program. We also cover all benign gynecologic complaints that women may develop in their lifespan, including minimally invasive gynecologic surgery for fibroids, endometriosis. Dr. Stephen Hilders really heads up the reproductive robotic surgery program in our department. And we also have, division of urogynecology and specialize in menopause medicine. We also have a robust gynecologic oncology division, which specializes more in women that develop uterine, ovarian, and cervical cancers. We're really proud of our training programs here at Houston Methodist Hospital, focusing on women's health. So we have an obstetrics and gynecology residency program. It is a 4-year program, and we take 5 residents per year. The specialty of OB-GYN is becoming more and more, women that are becoming obstetricians and gynecologists. In fact, more than 80% of applicants to OB-GYN residencies are female, and actually our training program now is 100% female trainees, which I'm very proud to say, since we're focusing on women's care. This is a competitive residency program. We get over 600 applicants per year for the 5 resident spots. We also have the first ACGME accredited urogynecology fellowship here in Houston. The specialty is called female pelvic medicine and reconstructive surgery, and it started in 2017, and we have 1 fellow per year for a 3-year program. So we're very excited to be training, the future generation. As for community outreach, we definitely help serve the underserved community around Houston for both obstetrical care, and we also do have an outpatient urogynecology clinic at El Centro de Corazon. So we're proud of that. And as for research, we have a lot of research going on in our department. So for gynecologic oncology research, Dr. Kamat has teamed up with some of the scientists from Texas A&M and the Houston Methodist Research Institute, and just got a grant with the Cancer Center to really look at nanoimmunotherapy targeting liver metastases and ovarian cancer. We also are one of the sites for the gynecologic oncology group trials, the GOG trials, which all of our gynecologic oncologists through our Houston Methodist system participate in. And this is funded by the National Cancer Institute, and this really helps us in our specialty to develop new treatments to target cervical cancer, endometrial cancer, and ovarian cancer. As for urogynecology research, we have a lot of different topics we're researching through our fellowship, and this includes healthcare disparities. One of my focus and research is on sexual function after reconstructive surgery. We have also partnered up with some of our faculty in the Breast Cancer Center, looking at the safety of vaginal estrogen use in women with breast cancer. We also have some studies looking at vaginal and urinary microbiome. Research looking at childbirth trauma and risk of pelvic floor disorders, Botox administration for overactive bladder, and then we have also partnered up with some specialists at University of Houston and really looking at communication research and qualitative research, looking at women's perceptions of pelvic floor disorders and maybe barriers and access to care there. As for our obstetrics research, some of the topics we're looking at right now are attitudes towards group prenatal care, obesity and pregnancy, and also the development of a postpartum app, which is in partnership with the NMed medical students. Looking at some of our innovative technology we utilize in our department, We have a large, a robust Da Vinci robotic surgery program here. We currently have 9 Da Vinci Xi robots here in the medical center at Houston Methodist. 2 of them are dedicated to our gynecology surgeons. And this really helps us to, procedures that were traditionally done, larger open surgeries such as large fibroids, can now be done with small incisions via the robot. There's also a newer technology called V-Notes that is a system that allows for laparoscopic surgery through the vagina. Now, as a vaginal surgeon myself, a lot of surgery I do just traditionally through the vagina, but what this allows is for someone that has, say, ovarian cyst or more scar tissue than expected, we can still avoid any abdominal incisions and operate laparoscopically through vaginal port. And then we also have the Mona Lisa Touch CO2 laser, and this is a fractionated CO2 laser that we actually utilize in the office, and it is used to treat vaginal dryness and menopause, and also a skin condition called lichen sclerosus. And there's more and more robust research going on looking at the utility of the laser with very promising findings. So I'm also going to just talk a little bit about my specialty in urogynecology and pelvic health, and really going over what are pelvic floor disorders for women. So what are pelvic floor disorders? Well, they're really just weakening of the pelvic floor muscles or tears in the connective tissue, and this can result in not only loss of support of the pelvic organs, but difficulty with bladder and bowel control. It's a very important quality of life issue in women. The 3 main pelvic floor disorders we see, the most common one is urinary incontinence. I also see and treat vaginal prolapse, which is when the vagina and the bladder and sometimes the uterus can drop externally from the vaginal opening. And then accidental bowel leakage is another common pelvic floor disorder. So these are really common in women. Approximately 25% of women will have at least one pelvic floor disorder as they age. And the estimated number of women that suffer from these PFDs are estimated to increase. One big epidemiologic study showed that approximately 28 million women will suffer from PFDs in 2010, and it's estimated to increase to 44 million in 2050. And this largely has to do with, the aging population, baby boomers getting older, and also women living longer, healthier lives. And then 1 in 5 women will require surgery for a pelvic floor disorder during their lifetime. And there's many women that, despite being seeing how common this is, may not seek care initially because they're embarrassed or they feel like, there's no good treatment options out there, which we'll talk about. There are. And some may just be embarrassed to seek care. So I think it's very important to break the silence and talk to your physician if you suffer from these disorders. So the next question I get is, am I at risk of developing PFDs? And as you can see here, there's a pretty extensive list. The most common risk factor is vaginal childbirth and pregnancy. However, even though vaginal childbirth is the largest risk factor, women that even have C-sections or that are pregnant can still develop PFDs. And then the other big risk factor is advancing age and older age. So other risk factors such as obesity, chronic constipation, previous hysterectomy, and there's certain genetic disorders that can put you at risk. But really looking at this list, the answer is yes, at some point in age, we will all have a risk factor for PFDs. So we'll talk a little bit about treatment and also some prevention. So for urinary incontinence, this is the accidental loss of urine outside the bathroom. It is the most common of all the pelvic floor disorders. There's really 2 main types that we tend to see, which is stress incontinence and urge incontinence. Now, stress incontinence is really from weakening of support of the urethra and the bladder neck, more common in younger women after childbirth, but certainly can worsen as we age. And really any increases in pressure in the abdomen, such as a cough, laugh, sneeze, exercise or jumping can cause leakage, whereas urge incontinence or overactive bladder is more common after menopause and can be also linked to genitourinary syndrome of menopause from that lack of estrogen can cause more of an overactive bladder, more urgency and leakage on the way to the bathroom. Both of these can be very distressing and impact the quality of life and have large impacts, both emotionally to women, but also has a huge economic impact in our country. So treatment of urinary incontinence, there's both behavioral and conservative treatment options as well as surgical options. One of the big ones is pelvic floor physical therapy, which is not everywhere, but we have a great program here at Houston Methodist spanning across our system that have, these are very specialized physical therapists that are trained to help, women that suffer from these pelvic floor disorders. And, there's also, they help to kind of retrain the bladder to kind of hold more urine and do some of those behavioral things that can also help. And we'll talk a little bit more about pelvic floor exercises in a minute. There are medications that can help overactive bladder, and then there's office procedures and surgical options as well. So for stress incontinence, that's very much surgically treated if exercises and physical therapy don't help. There's minimally invasive surgeries such as slings, bladder neck suspensions, and then there's also a more innovative approach, a urethral bulking injection that can be done in the office. And actually the newer forms of it can last several years, and so that is great, for patients that don't want to undergo a minor surgical procedure. And then for overactive bladder, if medications and physical therapy fail, we can inject Botox in the bladder, and there's also innovative nerve stimulation that helps. As for treatment for prolapse, similarly, there's some conservative approaches, such as a pessary, but there's also minimally invasive surgical options, either done vaginally, laparoscopic, or robotic. The vast majority of these are outpatient, going home the same day, and we can either utilize your native tissue, and there's some cases where we may need to utilize lightweight mesh in those cases with more severe prolapse or recurrent prolapse. Pelvic floor muscle exercises are extremely important. Even if you're not suffering from a pelvic floor disorder, we don't want you to develop one. And like I said, all of us as women are at risk. So I'm very proud to show that the handout there on the side was developed through one of our focus group research studies talking to young mothers at risk on how we can best educate women about pelvic floor exercises and how to do them. But I think this is a great opportunity right now because everyone listening, whether it's a woman or a man, can do pelvic floor muscle exercises. And I think the main thing is just to get in the habit of remembering to do them. We go out to the gym, we exercise other areas of our body, but we really need to exercise our pelvic floor. It is not only important for bladder and bowel control, it is important for sexual function. So how we would squeeze our pelvic floor muscles is you want to lift and contract the pelvic floor muscles for several seconds and then relax for several seconds. You want to try to do 10 contractions at least 3 to 4 times daily, or you can do them all together. These are the same muscles you would contract when you're trying to stop urine flow, although it's not good to get in the habit of doing that because your bladder muscle should be contracting as you urinate, and so even though those are the correct muscles to use, you don't want to routinely do that when you're urinating. They are the same muscles you would contract when you're trying to stop from passing gas. So I just encourage everybody to be aware of how to do those exercises and be proactive with them. We do have a Center for Restorative Pelvic Medicine here at Houston Methodist, and a lot of these are pelvic floor disorders that come through the center, but we also treat several other diagnoses, sexual dysfunction, chronic pelvic pain, neurogenic bladder and bowel issues as well. Not only do we have urogynecologists and FPRMS specialists, but we also have general urologists and gynecologists, colorectal surgeons, sex therapists, physical therapists that can help women and men restore pelvic organ health and help the quality of life. So, and we really have made this a system-wide center with multiple CRPM sites. So I hope that if you know of someone or you are suffering from a pelvic floor disorder, know that there are specialists out there to treat you. And that's all I have today for my part. I would like to introduce Dr. Bohart for her talk.
Hi, good morning. I'm Kathleen Bohart. I'm one of the general gynecologists and obstetricians here at Methodist, here in the Medical Center. Just going to talk to you today about a couple updates with gynecological cancer screenings and a little bit more about our obstetrics program here at Houston Methodist. We have an obstetrics program at all of the surrounding hospitals, including Clear Lake, Woodlands, out in Willowbrook, Baytown, and here in the Medical Center. Here in the Medical Center, I'm going to talk about our rooms and our LDRP model here. We have over 1,500 deliveries annually. We're very proud of our Level 3 maternal designation and our Level 2 neonatal designation. We're also part of the Texas 10 Steps program, which I'll talk to you more about, and how we're trying to increase breastfeeding rates in the community and prevention of the first birth cesarean. One of the things that makes Methodist very special is our labor, delivery, recovery, postpartum rooms. This is called the LDRP model. This allows women, when they check in, to labor, deliver, that postpartum bonding time, and the postpartum recovery to be all in the same location. This decreases any interruptions in your care, allows better bonding with baby, and then if we run into an emergency postpartum, you're already in the best place possible. The Level 3 maternal designation is really important because not only do we treat low-risk women, we also can treat significant complex medical and surgical conditions. And these specifically include our high-risk cardiac patients as well as our neuro patients. In order to receive the Level 3 maternal designation, we have to have access to specialists, surgical specialists, and behavioral health specialists. The on-call specialists involve neonatology, anesthesia trained in obstetrical care, maternal fetal medicine, critical care and ICU specialists, and as well as an expansive blood bank. Something that has significantly decreased morbidity and mortality in women is massive transfusion protocols, which our hospital has, since maternal hemorrhage continues to threaten women's lives worldwide. The Level 2 neonatal designation, we have a special care NICU nursery, on-call neonatologists, as well as anesthesia trained in the neonate. We also have a partnership with Texas Children's that if we have an infant with higher level of care that is needed, that we are able to transfer them and have their neonatologists here. The Texas 10 Steps program, the mission of this is elevating the standard of care for mothers and babies. This includes not only having lactation consultants, but also training all of our staff in lactation. We do a rooming in model, which does not separate the mom from the baby. This will help with on-demand feeding, being able to teach moms hunger cues and when to feed, as well as skin-to-skin contact immediately after delivery. This is done both in vaginal deliveries and C-sections. We try not to separate mom and baby for that first hour and try to initiate breastfeeding as soon as possible. Feeding on demand is really important too, and training new moms on how to know when baby's hungry instead of focusing on putting them on a schedule. And then as well as our staff training with lactation. Another thing that there's been a lot of research in and a lot of interest is preventing the first birth cesarean. The numbers that you look for when you compare hospital rates is the NTSV, which is the Null Paris Term Singleton Vertex delivery rate. The national goal is 24%. Many hospitals report around a 34 to 35%, and Methodist has been substantially under the national goal consistently year to year. Next, I'm going to talk about gynecological cancer screening guidelines. First, let's review the most common gynecological cancers. We have uterine cancer becoming the most common gynecological cancer. 26 cases per 100,000 women, and average age of diagnosis is 63 years old. Next is ovarian, cervical, vulvar, and then vaginal. Cervical cancer used to be one of the top 5 killers of women, and it's not even in the top 10 list anymore because we've made a lot of headway in screening for cervical cancer. Vaginal and vulvar cancers are more rare. This is why it's very important, even if you don't need a yearly pap smear, that you're still coming for pelvic exams so that we are able to check for abnormal moles and skin lesions. For cervical cancer screening, no wonder the public is confused about exactly when you need screening, because here are the recommendations. The cervical cancer screening is specifically the pap smear. The pap smear is a brushing of the cells from the mouth of the uterus called the cervix. HPV is what causes cervical cancer. HPV is very common. Some studies show up to 80% of the US has it at some point in their life. The good news is that the majority of patients will be able to get rid of this virus on their own. We've also made a lot of headway with cervical cancer because of the Gardasil vaccine. This is recommended in ages 11 to 14, and now it has been FDA approved up until age 45. So cervical cancer screening, well, women begin at age 18 years old, but we do not do routine screening under the age of 21. The thought process is that after you're exposed to HPV, it does take a while before it becomes clinically significant and starts to cause changes in the cells that we're concerned about. Ages 21 to 29, we start with cytology, which means studying the cells. When they scrape those cells, they get looked at to see if there are any that are cancerous. From age 30 to 65, there are several different methods that are available depending on what patients have access to. Here at Methodist, we use co-testing, which involves not only looking at the cells, but also testing those cells for the HPV virus. If you have 10 years of negative PAPs leading up until age 65, no further screening is required. The thought process of this is that if you have not had a HPV, then your risk for cervical cancer is very low. Now, we're PAPs only screen for cervical cancer, and I think that's a really common misconception. Women wonder, well, if I don't get a PAP, how am I going to know about uterine cancer or ovarian cancer? But the PAP does not check for that. It only screens for cervical cancer. And then if you've had a hysterectomy or removal of the cervix for non-cancerous reasons, then you no longer need a PAP smear also. Remember that PAP smears do not equal pelvic exam, so you still need to come in for your clinical pelvic exams. You'll often find too that many doctors won't space this out to every 5 years. I personally in practice tend to do them a little bit more frequently. I think we've made a lot of headway on cervical cancer, so we'd hate to lose any of that groundwork. Also talk about your individual risk factors with your doctor. If you're having new partners, history of HPV, history of abnormal PAPs, these are people who we might not want to space out to the every 5 years. Next, let's talk about uterine cancer screening. Now, there's no standard or routine screening test, but this is usually almost always found stage 1. The reason for that is that women know that bleeding after menopause is not normal, so that often prompts women to come in and make an appointment. The other big symptom is abnormal bleeding after the age of 45. Risk factors of why this is increasing in the U.S. is higher rates of obesity, never giving birth or having less children than women historically had in the past, family history, and as well as hormone therapies. As far as ovarian cancer screening goes, there's also no standard or routine screening test. Tests that have been studied have been a CA-125, which is a blood draw, as well as pelvic ultrasounds and pelvic exams. The tough part with ovarian cancer is by the time we're able to see clinical symptoms, patient having symptoms, or being able to find this on a screening test, it's often at advanced stages. As far as symptoms go for ovarian cancer, bleeding after menopause, pelvic pain, bloating, we have a very low threshold to do a workup on a patient if you come with some abnormal symptoms. Risk factors for ovarian cancer is never giving birth, and then about 20% of ovarian cancers are genetically related. Risk reductions for ovarian cancers: women who have had their tubes cut to prevent pregnancy or removal of the tubes significantly decrease the risk of ovarian cancer. The longer you breastfeed, this also reduces the risk of ovarian cancer, and the use of birth control pills. For breast cancer screening, here's another slide. No wonder women are confused about what exactly to do. There are 4 main bodies who are making recommendations on this: the American College of OB-GYNs, the U.S. Preventative Screen Task Force, American Cancer Society, as well as the National Comprehensive Cancer Network. Each of these make different recommendations based on different endpoints. For the U.S. Preventative Task Force, their recommendations were to not start mammograms till age 50 and to space them out every 1 to 2 years. This was based on not increasing the mortality rate to women, but also decreasing anxiety and the amount of false positives. Here at Methodist, we still continue to follow the American College of OB-GYNs recommendations, which is a mutual decision making. It is reasonable to start mammograms at age 40 and continue them yearly as long as you're in good health. We're seeing a large increase in breast cancers. It used to be 1 in 8, and now it's almost 1 in 6. And the reasons for this are, the reasons for increase for other gynecological cancers. Decrease in the amount of children that we have, decrease the amount of breastfeeding, increased risk of obesity. This is all for low-risk women. And so if you have a family history of breast cancer, if that does not put you in the low-risk category, you need to talk to your doctor. There are certain models that we can run and numbers that we can calculate to try to calculate your lifetime risk of breast cancer and help make a better decision on when to start screening. Thank you so much. I hope that helped clear up some of the recommendations for cancer screening. The big thing with so many women missing care during COVID is that we want to get you back in. We want to get you up to date on all of your screening. Do not be embarrassed if you have not been in a while. We would love to see you back. Next, I'm going to introduce Jessica Rohr. She's one of our clinical psychologists and director of women's mental health here at Methodist.
Thank you, Dr. Bohart. Hi, everyone. I am just delighted to be here today to talk with you about something that is an incredibly important topic and that I am very passionate about. So I'm going to get right into it so that I can get through it. Today I'm going to talk briefly about why is it important to talk about women's mental health, and then I'll talk about our department's lifespan approach to the understanding of women's mental health, and then our strategy and long-term goals for serving the Houston women. Why women's mental health? I wanted to give just a brief history of why it is important to discuss not just women's mental health, but women's health. Why is it important that we talk about men and women separately? We're different. There are differences from the cellular level all the way up to the societal level between men and women. We experience diseases differently and we respond to treatment differently. So for those very important reasons, we need to have a solid understanding of how men and women experience and respond to treatment for these diseases. I want to talk a little bit, though, about some of the gaps that have led to our current state of research and clinical work for women's health. Where we are now, women have been underrepresented in the research, and thus we have an underrepresentation in knowing what to do with women's health and women's mental health issues, and I'll talk a little bit about why. So in the 1960s, there were some clinical trials for a medication called thalidomide. Many people may know about this already or remember this. It was a tragedy. There were many children born with birth defects and many deaths because pregnant women were included in the trials. As a reaction to that, the FDA excluded women with childbearing potential from early phase drug trials. What ended up happening, this translated kind of practically to all pharmaceutical research. Women with childbearing potential weren't included in pharmaceutical research. Women with childbearing potential includes any woman who is premenopausal. That's all the women, regardless of whether they were single, planning on having children, on birth control, partnered with someone who was sterile and they couldn't have children with. So this was a massive removal of a major important population from the research. In 1990, advocacy groups were sort of screaming, saying, where are the women in the research? We need women to be involved in the research for treatments for women's issues. So the NIH developed the Office of Research on Women's Health to start addressing these issues. And then in 93, the FDA changed those guidelines. What that essentially led to, though, is about 16 years of virtual exclusion of women from clinical research. And again, although it was initially from early phase drug trials, this had a trickle-down effect to almost all clinical research, and I can even speak for research on mental health as well. So where did that leave us? Not just human women are underrepresented in clinical trials. We also see that female animals are underrepresented in clinical trials. And there are some interesting reasons as to why. One of the reasons that has been discussed is because the experience of the menstrual cycle in female animals makes the research more confusing, which I think we can all say menstrual cycles are confusing, but it is also an important factor of premenopausal women's life that they have menstrual cycles. So this chart over here, the blue lines refer to how often in a disease it occurs in women. So for anxiety, for example, 70% of people with anxiety are women, but only about 40% of the animals in the preclinical trials on anxiety medications were female. So we have these vast discrepancies between the prevalence of these disorders in women and how often they were actually tested on female animals. When we do look at sex in these studies, often researchers can statistically control for it, so we can use statistics to just pretend it's not there, or we can not analyze it at all. A really interesting time that this happened recently was with the COVID-19 mRNA vaccines. So they did a great job. The clinical trials for these vaccines were split pretty evenly between men and women. What they did not ask was, were there any impacts on the menstrual cycle in women? And then once people started getting the mRNA vaccines and started noticing my menstrual cycle is different, it's longer than usual, we started to see some hesitancy and I would talk to some patients about some skepticism about continuing to get the vaccine series because they were worried about the impact on their reproductive health. We've since found out that it can increase your menstrual cycle about 1 to 2 days, but it's temporary. It's just for that month. But that would have been really good to know in the clinical trials to begin with. And we can't know what impact that had on people choosing to delay or not get the vaccine. And just another point, just to kind of hammer home why it's important that women be involved in this research. In this short time period after that change from the FDA, they found that 4 of the 10 drugs that were withdrawn from the market were because of the severe adverse side effects in women. Because when female animals and then women are not included in the early parts of the trials, then we don't know about the biological impact specific to women of these drugs. And so then a lot of clinical trials can end up failing or going to market when they actually could hurt women. All that to say, it's important that we do this work. So where has this left us with women's mental health? Like I said, it was a trickle-down effect for all mental health. And if I could go, I'm not going to go back to the slide, but this was also a time of huge expansion in research. Research is moving very quickly with these technological advances, with increased funding. So there was a lot happening that women weren't included in. So where has this left us? With these limits on research, we end up having lower levels of evidence-based practices that are specific for women's issues and practitioners who are experts in those. Without that, we have less of an ability to impact public policy and then less of an ability to impact managed care coverage for the different issues that women face. And that directly impacts access to care, which is very important to all of us. And that's what we're going to fix. So with our lifespan approach to women's mental health, I wanted to kind of go over our conceptualization of women's mental health. So rather than it being sort of a piecemeal approach, here's a list of disorders that we think of with women, I'd like to think about it as how can we think about these happening across the lifespan? And that's because women have several major hormonal fluctuations. And around these hormonal fluctuations in their lifespan, we can see clusters of psychiatric issues that can come up, either exacerbated by the hormonal fluctuations or brought on by the hormonal fluctuations. And one of those is puberty. And puberty is not unique to women. Women and men go through puberty. But if everybody could kind of think about what it was like to go through puberty, that's a time when a lot of hormonal fluctuations, your body's changing in ways that are really confusing, your emotions are kind of up and down, and also that can be very confusing. Maybe you're getting body hair, you're sweating more, you care about things that are different, your brain structures change. This all happens during puberty. After that, though, women have a few more. We do it at least one more time, and for women who have children, 3 more times, if you only have one. And the reason I kind of compare that to puberty is some people have talked about these other times as additional, you can call pregnancy and postpartum matrescence instead of adolescence, because I want to emphasize that these hormonal fluctuations come with all of those other experiences along with it. So we do experience those multiple times in our lives. So starting with puberty, this is mental health concerns that uniquely impact women. These aren't only things that come with puberty, but these are initiated with puberty if you're going to experience them. So premenstrual dysphoric disorder, this is a disorder when women experience about a week before their pregnancy. I think a lot of people know about PMS or premenstrual syndrome, where you can be more irritable, a little sadder, maybe feel a little bit more vulnerable to emotion. Premenstrual dysphoric disorder, or PMDD, is a more severe version of that. So you feel a dysphoria, which is like a deep sadness. So I'll have women tell me, I get suicidal about once a month right before my period comes. And I'll say, well, that's not normal, actually. That's PMDD. I can't get out of bed, I can't go to work, the pain is too intense. So that's something that we're starting to learn a little bit more about. Also, mood changes secondary to hormonal contraception. Though hormonal contraception is a godsend for many women, I think a lot of women can think back to the experience of trying to find the right one, right? And so for a lot of women who get on hormonal contraception during puberty, there's a lot of mood changes that can come along with it that can be very distressing and very disturbing. Moving on to pregnancy, there are some of the mental health concerns that are associated with fertility challenges. I would say about a quarter of my patients now are women who have struggled to get pregnant, who have gone through IVF, and we talk a lot about the trauma and grief that comes along with that process. It's a very sad and lonely process. And it's one that people don't talk about a lot. And that'll come up a lot through here. It's things that people don't talk about a lot. And like Dr. Antosh said, that's one of our major goals, is speaking these so that we know that we can talk about them. Miscarriage, it's fairly common. 1 in 5 women will have a miscarriage, a known miscarriage. It does not mean it's any less painful. It can be a considerable loss with a lot of grief. And it being more common does not make it easier. And then prenatal psychiatric illness. A lot of us know about postpartum depression. Many people don't know that postpartum depression many times begins in the prenatal period. And we really want to get a better understanding of how that works and how that's, of the etiology for that, because we know that it can impact the experience of childbirth. It can actually lead to premature childbirth, and it can lead to a lot of negative postpartum outcomes. Postpartum, like I said, I think most people have started to learn more about postpartum depression. We also have postpartum anxiety, so where it's not so much a sadness, but more of a feeling anxious and nervous, doing a lot of checking of the child. If there's too much checking or having some really intrusive thoughts, it might be a postpartum OCD. There's also postpartum psychosis and postpartum PTSD. In the past 10 years, we've been learning more about postpartum PTSD. The experience of childbirth can be quite traumatic, and our definition of a trauma is an event in which you fear for your life or for that of someone else's around you. And even in the most successful childbirths that maybe seem to go very easily, a lot of women fear for their life or that of their child at some point in the process. So we are learning more about PTSD related to childbirth, or PTSD exacerbated by the hormonal changes. And finally, menopause. And we were talking earlier about how I was almost embarrassed writing just ongoing mood shifts and changes. We don't even have a true name for what happens during menopause, which I think speaks to how much we still have to do in terms of really understanding what's happening in menopause. But there's a little bit different about menopause from puberty, pregnancy, and postpartum. Those are pretty discrete experiences. Pregnancy lasts 9 months. Postpartum, it's about a year unless the mental health issues that develop during postpartum remain untreated. Menopause can go on for years between perimenopause and actual menopause. It's unpredictable. It's something else that people don't talk about a lot, and it's very uncomfortable. I have a patient who was just delighted because she had not had her period for 7 months, and she just got it last week. And so there's just a lot that kind of goes into this experience of menopause, including all the other difficulties of cognitive changes, sexual function changes, things like that. I did want to briefly touch on a few of the mental health concerns that disproportionately impact women. So these are not unique to women, but do disproportionately impact them. We are twice as likely to meet criteria for depression, 1.5 times as likely for anxiety, twice as likely to develop PTSD after experiencing a trauma. And one of the reasons that we think that is because certain traumas have differential loading for PTSD. So what that means is there are a lot of different things that are considered a trauma. Some of them you're more likely to develop PTSD from. They're more damaging and emotionally. And one of those types of trauma is sexual violence, and women are more likely to experience sexual violence. And then eating disorders, specifically those related to thinness and weight, they're more common in women. I'm not going to go through all of this, but these are common medical disorders for women that do have a large psychiatric burden. And what I mean by that is that they can either be exacerbated by psychiatric issues, by anxiety, depression, or the experience of the disorder can lead to psychiatric issues. We talked earlier about some of the shame and embarrassment that can come along with some of the pelvic disorders. These are things that I end up hearing about a lot. So what I want to do is talk through our approach to improving women's mental health. And there's a lot to do. We have a small department. We are growing. We've only been really specifically directly working on women's mental health and growing this field for about 9 months. And so we are taking kind of a scalable multi-method approach where we want to get a lot of pieces in place in a specific area and then grow from there. And the area that we're focusing in on for now is maternal mental health. So the pregnancy experience, the postpartum experience, and then being a mom. And there's a few reasons for doing that. One, we have, I have 100,000 in my head, but we have over 100,000 births in Houston, and we think every year. And we can expect that about 20% of those women will develop some sort of postpartum issue. So about 20,000 women. We have maybe less than 30 practitioners in the mental health field who focus specifically on the maternal mental health concerns. So this is a need. This is an area of great need, and we really want to start to fill those gaps. Also, on a personal note, I experienced postpartum depression after my first baby, Ava. I was a psychologist. I've been a psychologist for 10 years. I was a psychologist who focused specifically on women's mental health and trauma. This is something that I probably I thought that I should have been able to avoid. And it was a humbling experience, and I came out of it with a passion for working to ensure that that we can get into ways of preventing these things from happening for women in the future. So that's where we're focusing right now. And I'll talk you through what we've done in the past 9 months because it's a lot, and we're excited about where we want to go. So starting with research, we've submitted a few grants intramurally, extramurally. We're interested in learning more about pregnant women and knowledge about mental health. This is in collaboration with OB and OB-GYN. We are looking at integrating wearables for continuous monitoring of the prenatal process. This is a collaboration with Rice. And we have a service grant with TCH where we provide in-home therapy for postpartum low-income moms. It's on different skills for postpartum depression. Clinically, we're providing evidence-based individual therapy in our emotional health and well-being clinic, which is the department's clinic that serves our Houston Methodist employees and dependents who are on the Houston Methodist Health Plan. My caseload is 100% moms, and that's who I'm working with. We also have evidence-based group programming called Moms Under Pressure. And when I say scalable, each of these we have plans for growing and continuing to grow our extramural funding so that we can grow each of these. For training, we will have a postdoctoral fellow in women's mental health starting in September. We also have, we're creating opportunities for collaborating with our OB-GYN residents. We're training clinical psychology interns. Training is where I'm really passionate about how we can help these women as quickly as possible, because the more that we can get trained in these areas and then send them out to continue doing this work, the more quickly we'll be able to serve the needs. And finally, within the community and the institution, we're providing education for and consultation for some community organizations in the area. We've also been collaborating here at Houston Methodist with the employee resource group. So just last month, I did a talk on how to talk about emotions with your children, where we talked about emotional coaching with your children, how to talk about mental health with kids, given the current mental health crisis. And this is where we hope to go. This is the Women's Mental Health Program or Women's Mental Health Center that I'd like to have one day. We'd like to have a Center for Excellence for Women's Mental Health. That's going to be a novel and innovative approach that integrates all of the different, like I said, going back to the lifespan, rather than considering it all piecemeal, that there are well-integrated programming for women to be able to deal with all of these issues. And our hope is to grow research, clinical work, training, and those community collaborations throughout the lifespan so that we can start to better serve our women. Thank you.
Well, I want to thank all three of you for fascinating talks as always. Got a number of questions that have been coming in, as well as a couple of questions that were sent in previously. I want to start with one that came in online here, which is about treatment for PMDD. You mentioned it a little bit, but could you go into a little bit more depth about what it is, how it's experienced, and then how it can be treated?
Absolutely. So PMDD stands for premenstrual dysphoric disorder, and I spoke about that earlier. It is an experience where about a week before your period starts, rather than having kind of the normal PMS symptoms, women can have sort of a deep dysphoria, a depression. It can come along with suicidality, not wanting to get out of bed, not wanting to do work, just a depressive episode, but right before their period. Right now, and I think this is a really good example of how limited our resources are for clinical care for PMDD. I know, and I almost want to look at Dr. Bohart and see if she'll fill in my gaps here, but pharmacologically, the first line treatment is an SSRI for PMDD, so that's a type of antidepressant. And then sometimes people will also, if the person's not on some kind of hormonal birth control, they'll be put on a birth control to try to moderate those hormonal shifts. I know kind of anecdotally, sometimes people will encourage their patients to skip the placebo pills so that you just have a steady state of hormones. And then from a therapy perspective, we're sort of just using kind of the cognitive behavioral therapy to work through some of the thoughts, and a lot of acceptance and commitment therapy. That's a type of therapy that's very focused on accepting the current experience and committing to what you want to do anyway, knowing that there may be some pain involved. Do you have anything to add to that?
Dr. Bohart.
So I think understanding the physiology of it is really important. Women experience something called a luteal phase, and this is from ovulation until your period starts. Once that egg is released, a cyst is left behind on the ovary that gives high doses of progesterone. With those high doses of progesterone, those affect so many different levels in your body, including serotonin. So as Dr. Rohr alluded to, you can do SSRIs, selective serotonin reuptake inhibitors, and we can do them two different ways. We can do them from ovulation until the start of your period, just during that 2-week time to help with those levels. Many patients, while this is an acceptable route, they'll continue to take them the entire month because they'll find that it will help with maybe some of the other symptoms they're experiencing. The other thing we can do is we can suppress ovulation. We can stop that signal that releases the egg that increases the progesterone, and this is where hormonal birth control comes in. Oftentimes we can do this with birth control pills. The Mirena IUD can also contribute to this also because it suppresses ovulation about 80% of the time. It shuts off that signal. There's also birth control such as the Nexplanon, which goes in the arm, and this will also suppress ovulation. So there's a lot of good options for women who can't take pills, for women who are trying to avoid hormonal birth control. Other things, when PMDD is not a severe or severe PMS, sometimes even just melatonin during the luteal phase, as well as extra vitamin supplementation can help with some of the peak in progesterone.
Perfect. Well, thank you. That's
Yeah.
very helpful for both
Yeah.
of you. Thank you. Dr. Antosh, I want to change gears here, talk a little bit about pelvic floor disorders. You talked about how common they are, which means there's many people here I know watching today who are experiencing that, have experienced that, may have had procedures or other treatments. When is it appropriate to come in and see somebody who specifically specializes in that as opposed to seeing your OB-GYN along the way? And then I also want to ask you a question because a recent talk we actually had urology here, and we have great specialty in our urology department around this as well. Talk a little bit about how we meld gynecology and urology as we address these issues.
Yes, so they are very common, and I think what really makes it more of a pelvic floor to address with a specialist is when it becomes a really bothersome quality of life issue for women. If a woman has a little bit of incontinence or prolapse, but it is not bothersome to you, you don't have to seek treatment. Now, if you want to kind of get on top of things and really get to pelvic floor physical therapy or do exercises, that's great. And I really encourage that. You do need a doctor's referral to a physical therapist. But in terms of seeing a urogynecologist or an FPRMS specialist, really if it's interfering with your quality of life, I mean, you don't have to suffer with these issues. It is not necessarily it's more common as we age, but it's not normal, right? So I think when you get to the point where it's really interfering with your quality of life, you're having to wear pads, you can't go, some women can't even go out and do social things because they're worried about where the bathrooms are. I mean, this is on the same level as chronic back pain with the amount of distress women go through with some of these disorders. So like I said, said, bring it up to your provider. If you don't know who to see, which specialist to see, you can always go through the Center for Restorative Pelvic Medicine. You can also talk to your OB-GYN or your primary care doctor about it. So those are always good places to start. In terms of at Houston Methodist, and there is a lot of overlap between, OB-GYN and urology, FPRMS is a specialty you can actually specialize in either through OB-GYN or urology. So we have FPRMS specialists here at Houston Methodist that are OB-GYN trained, such as myself, Dr. Kobashi, and some people in urology that are also fellowship trained in FPRMS. And we really do have a close collaboration. We all work together to help take care of these women with pelvic floor disorders through our CRPM and Center for Restorative Pelvic Medicine. We also collaborate in research and training. So we have fellowships that we do jointly together and research together. So it's a very collaborative environment, really working on both translational and clinical research to really help better serve women with these issues.
There was another question that came in about what's paid for. I mean, because as you said, there's a spectrum of things you can do, obviously from preventive and exercise and things to some in-office procedures to larger procedures, although almost all of them still, thankfully, you go home the same day.
Yes.
But which of those are paid for, not paid for, and how do you navigate that with a patient?
That's a great question because I get that a lot just when I give talks and that sort of thing. Even though these are quality of life issues, they're important medical problems, and they are generally covered by insurance. I very rarely have an insurance that will refuse, to do a physical therapy or to get a procedure if they need it. I mean, sometimes insurances will say you need to try these conservative things or medications first before you can get to, some of the more procedural things. But for example, for prolapse, I mean, I've never had an insurance not cover, a surgical procedure for that if a woman needs it. So.
Good. Well, that's obviously good news for
Yeah.
those who are insured. That's the other part's a whole other big topic, unfortunately. And we'll talk a little bit about some things with that as well. So a couple questions in different threads I want to ask you, Dr. Bohart, around timing of screening. And of course, certainly in my career as a primary care physician, kind of the recommendations that you showed have changed quite a bit, particularly around pap smears, for example, and the timing of cervical screening. And a couple questions I'd almost put as concerns that people have asked of, well, am I going to be missed? And, why is it more spread out? And should I see you still in between? And, what else should be going on? So go a little more detail on that.
Absolutely. We want to see you every year. And that way we can look at your individual risk factors and do we need to be doing PAPs more frequently? The thought process is that our pap smears have become more advanced than they used to. We used to just scrape the cells, they get looked at underneath a microscope and said, do these look abnormal or not? But now we can actually test the DNA of those cells to see if the virus is there that can increase your risk of cancer. I know a lot of Medicare patients worry that preventative coverage is only once every 2 years. That is just for an asymptomatic patient without any concerns. And so know that if you do have a concern or a new symptom, we want you to come in sooner, even if that was 3 months after your well woman exam. So this is truly for asymptomatic patients who don't have any concerns.
Okay, great. Well, that's very, very helpful. Thank you. You talked about our C-section rates.
Yes.
And had a question about what are we doing to try to decrease that? You talked about us being better than the national goals that are out there. Can you just go into a little more detail about how common C-sections are, not just in first birth, but the whole issue of second and third children and vaginal birth after C-section, all that? Could you just give a little more kind of overview of the landscape of all of that?
Absolutely. So there was a big change kind of historically, that we thought that increasing C-sections and decreasing operative vaginal deliveries was going to make things safer for moms and babies. We have found that even with the increase in C-section rate and the decrease of operative vaginal deliveries, we did not improve some of these outcomes that we had hoped to in babies. So over the last 20, 30 years, we've been really working hard to really respect the natural birth process, respect that this is a normal process that your body is supposed to go through, help support it, be there to step in when things don't go expected. With that, we're also very supportive of vaginal birth after cesarean section, which we refer to as a VBAC, or also sometimes referred to as a TOLAC, trial of labor after cesarean. Methodist is the perfect place to do this. There are several things that are required to make this safe for moms, including the ability to switch plans very quickly, including in-house anesthesia, neonatology, having access to emergency care 24 hours a day. And then if there's a 1 to 2% chance when women goes through a trial of labor that the stress of the uterine contractions can open the previous scar of the uterus, that if this were to happen, it's only about a 1 to 2% chance that we have the massive transfusion protocol, operating rooms available 24 hours a day. And so that's a big thing that improves safety. The next aspect is preventing the first C-section. Part of that comes with respecting the natural process of childbirth. The recommendations and our definitions of labor have changed significantly over the last 10 years. We used to think active labor started when a woman was 4 centimeters dilated. That has been pushed to 6 centimeters. The timeline that we give for women and that we recommend have increased significantly also. And I think this big move in patients, while keeping things safe for mom and baby, has helped significantly decrease this rate.
Perfect. Well, thank you very much. Dr. Antosh, I want to ask you a question that didn't come in, but you talked some about our training program specifically. Actually, both of you did a little bit. And you were thankfully and grateful to you for serving as interim chair of our department. Talk about the arc of our training program, the people that are in it, where they train and how they get their various experiences.
Yes, so our OB-GYN residents specifically, I think it's a very well trained program. The residents come out very well trained in doing obstetrics and gynecology, and I think one of the reasons is our diverse faculty we have here at Houston Methodist and our large GYN surgical specialty and volume. They really do see all aspects of gynecology here. And they get trained in all routes of surgery as well, vaginal, laparoscopic, robotic. And in terms of obstetrics, we have our great obstetrics programs here. They also do spend time at St. Joseph's Hospital downtown. About half of their residency actually has been covering that hospital and serving, some of those community hospital clinics that deliver mainly at St. Joseph's. I think some here as well. And so they get a lot of also their obstetric volume from that hospital. So they see a broad range of patient populations, procedures, surgical volume, and we just have really strong faculty, I think, to support that in both places. So.
And it sounds like we're recruiting really top caliber people.
Yes, when I found out from Dr. Harms, over 600 applications for 5 spots each year that he has to individually review. I was amazed.
It's a lot of work too.
A lot of work.
So, well, great. All right, well, a question came on that I mean, as the only guy sitting here in the room, I can't resist asking. I'm going to start with Dr. Brouwer, which is, do we have any programs for men to become more sensitive to the issues of their pregnant wives? Now, I'm wondering if that's a guy who wrote that there or somebody pregnant on there. My wife probably told me I wasn't very sensitive. I'm sure it still does. But talk a little bit about that.
I'm delighted to see that question because the number one factor for resilience from any type of difficult period is social support. We have seen that over and over and over again. And what I hear more than anything from pregnant women's partners, men or women, but mostly men, is that they really want to know how to help and they really want to know what's going on. Unfortunately, kind of the way things are now, we're still trying to play catch up with getting these services for women. We'd like that to be a part of our plan for our center, to have these partner services. We've talked about that a lot, doing partner groups, either separate men's groups. There are some resources in place already. Even what to expect when you're expecting. I'm looking at you to see if you have a weird face, but it's a great book and it's got things for partners throughout it that they can read, which I really like that. I'm not aware of partner groups here. Do you have?
We do. We have a prepared childbirth class.
That's great.
This is kind of a 2-part series. One of it is just, the actual mechanics of labor, what happens, what to expect. But there is another segment of it that's really important, and it's about preparing the new parents for what's going to happen. How does your marriage change? How, what are those feelings postpartum? How to help support a partner. I encourage the dads to also go to the breastfeeding classes because oftentimes immediately postpartum, you're not in your right mind, and it's nice to have someone someone who doesn't have these hormonal shifts happening to hear the information also. And I also encourage partners to come to all the prenatal visits. And we really do, we try to do a lot of education on what to expect, how to support, what are the natural physiological changes you're going to encounter, at each stage in pregnancy, and how to change things in your life to help, prepare for that.
That's great. Yeah.
Well, I want to ask our two physicians here, kind of what's most exciting to you on the horizon? What's going to change things most in the field coming up? I mean, certainly it struck me when you talked hard about, cervical cancer is dropped out of the top 10. That's pretty huge given how common that was. But I'll start with Dr. Antosh. What do you see coming down the pike that's really exciting you in your field?
Yeah, as I mentioned, there's definitely some newer technologies that are really changing the way we're doing things with gynecologic surgery. But I think there's still a lot of gaps in terms of research, clinical, translational, as Dr. Rohr had mentioned. So I think it's very important for us in our department to also explore those, leading medicine in this area. I think it's just a very important thing to explore in collaboration with other scientists and even other, hospital organizations, really to all come together to do really important research to advance women's health. So
that's great. Yeah. That's great. What about you?
Well, I think this is what's most exciting, in our field, that people are actually talking about women's health, that they're talking about menopause, we're talking about postpartum depression. I think that's what's probably most exciting, is that we're having these conversations, which means more funding for research, which means more research happening, and making more public awareness with it. And then kind of on a clinical, we received a question about this ahead of time about a blood draw for cancer screening. And this is going to be some really exciting technology since we don't have a good screening test. Currently, there's only 5 cancers that we really have screening tests for: prostate, lung, colon, breast, and cervical. And so some of these blood cancer tests that are going to be coming out, we've known specifically what this is checking for is cell-free DNA that's in the blood that's not related to your cells. We have known since the 70s that that cancers produce more DNA in different patterns in the blood. We've been using this technology in prenatal care for the last 10 years, looking for genetic abnormalities in unborn children. And I think we're very close, in the next 10 years of this becoming more mainstream, that we can do some of these blood draws to pick up on other cancers that we don't have good screening tests for.
Won't that be great I know there's some out there, they're not yet FDA approved, that are
Right.
being looked at very carefully.
Right.
The challenge always, obviously in your field in primary care, is always false positives and ending up going
Right.
down a lot of rabbit trails for people. And
Yeah.
that's been kind of actually one of the really challenging areas in OB-GYN for, we talked about CA-125 when I was in medical school,
Right.
25 years ago, 30 years ago, shoot, it was a long time.
And with
and we're still talking about it because
Right.
it's such a challenging diagnosis to make. Similarly,
And especially with the prenatal testing, the big benefit is the negative predictive value. That if someone gets a negative test, it's 99.9% that an infant does not have this. But it's really hard explaining to patients that with a screening test, the positive predictive value, even with a positive test, some of them only have a 10% chance of the baby carrying one of those disorders. So it's really, that the numbers with this is really difficult. How do you, apply it to large population in screening?
Right, and so I do agree. We're on the verge of some very exciting things in screening. I mean, that obviously will be great. Well, I'm going to bring things to a close here, and I want to thank all 3 of you for your great talks today and the great dialogue we had. And I'm going to bring you quickly an update around Houston Methodist. Always give you a little COVID update. Unfortunately, a little more COVID update today because it's coming back a little bit here right now, and we'll talk about some of that for sure. But I alluded to this earlier, and I wanted to shine a light on this. We had the most wonderful event about 3 weeks ago or so now at River Oaks Country Club called our Portraits of Perseverance Luncheon. It was for our Women's Health Initiative. Nancy Dinnerstein chaired that for us. It was just a fantastic event. How it was structured really was table conversations across the room with women who have persevered and who have excelled and led in their respective fields. I was at a table with an astronaut, for instance, who flew many space shuttle and ultimately missions to the International Space Station. So just absolutely really fascinating. And we had a keynote speaker of Marlee Matlin, who, as many of you know, was one of the key actresses in the Academy Award-winning Best Picture movie Coda this year. One of those lucky things through COVID, because we ended up delaying this event a few times for COVID, we actually had her signed on before anybody had any idea that Coda was going to be the #1 film. In fact, I don't even think it had been released back then. And she just gave a spectacular talk, both in terms of resilience and perseverance, the whole theme of the luncheon, but also in terms of inclusion and what it's like to be in Hollywood and elsewhere as a deaf individual, and just a spectacular event. I want to thank Nancy Dinnerstein and many others who helped drive that, and I'm sure there's some people here watching today who attended that. I hope you enjoyed that. We're already planning for next year's event, as you heard a little bit earlier from Marcy. I want to now give you an update around COVID. I'll also give you some other non-COVID updates for the institution. But this is where we are from a hospitalization basis. You've seen this chart a billion times. And the bottom line is, the good news is we're not whoppingly up. Now, I will say we got down to about 40, and now we're seeing 84 last night, peaking in the mid-90s during the daytime over the last few days. So clearly it has come up. But this is the reason why I think it's time for people to just notch up their concern a little bit. And this is our chart of the testing that we do. That's the blue bars. And then the percentage of those tests that are positive, that's the orange line. And what you see is both are up. And I say this with a caveat I'll show you in a second, which is lots and lots and lots of the testing is now being done in the home setting. I mean, as I had my cold this week, I think I'm not kidding, done 7 tests in the last 5-6 days. A couple were PCRs, several were rapid tests at home. And we don't get any sort of aggregate data on the tests that are happening at home. But nonetheless, we're now seeing this signal here at Houston Methodist. We've had over 100 people test positive each of the last 2 days. We haven't seen over 100 since mid-February. So you'll hear the message is not time to panic, not time to say, wow, I think we're going to go do the winter again. I don't think we're going to do that. But as I've talked about, we need to seize the safe moments safely, and we need to be ready to pivot. And this is not a time to hard pivot and suddenly dramatically change everything we're doing, but it is a time to be aware that it is out there, that it is increasing, and particularly if you're at higher risk, to start rethinking some of the things that you are doing. This is some of the data that also we need to really be cognizant of around the country. And that is, when they do some estimates and some other studies, a lot of the cases now are underreported. So we don't have quite the same visibility we did, because 18 months ago, you could get a test fairly easily, but it was all at some site that tested you and then, reported. Now, you can very easily get a rapid antigen test, which, I encourage everybody to have a whole bunch of those sitting at home. I do, and we do, and use those very frequently. And now's the time where get them on hand if you don't have them. Use them if you have even an inkling of symptoms, because really, to keep this down, one of the key things is, look, if you're sick with COVID, stay home. Don't infect other people. And sometimes you may not know it because it may be mild. So if you are having some symptoms, go ahead and get tested. This is what we see in the wastewater, and it's the same story here. Now, our wastewater is up to 170% of the kind of arbitrary date they chose to be a baseline. Not nearly where it was this winter, where it shot up to over about 1,000% or so. But each week up and up and up, and the positivity rate in the community is about 11%. That was as low as 3-4%. So we are seeing that increase as well. So again, time to be a little more careful. What's going on with that? Well, there's a whole host of reasons, I think. We've been talking for a while about how in the South and in Houston, cold, warmer weather, more indoor living, I think has been a factor each of the last 2 years. It's tough to tease it out because, of course, we had new variants coming in, particularly last year where the Delta variant came in and really caused things to explode. But I do think there is a factor with that, because we're seeing the South have some of those summer upticks, and then northern states kind of hit in October, November when it gets cooler, and then when we really get cool and indoors again, we catch up with them. Which variants are out there is probably a factor as well. This is US-wide, the variants that we have seen and the change of them. Now, for a variant to change, it generally has to have a competitive advantage. So what you're seeing here is a couple of lineages of Omicron. So these are all sort of, brothers and sisters and children of Omicron. right now. They are not a radically different variant, but what you see is a couple of them having taken over, and they're in the kind of BA2 lineage right now in the United States. We see pretty similar proportions to this when we measure at Houston Methodist. We're well over 100,000 genomes that we have sequenced now, but this is what we've seen in South Africa. Now remember, this is where Omicron came from, and this is what caused the start of the big surge that we saw around Christmas time. And what we've seen there is the BA4 and BA5 lineages. We have seen a smattering of those in Houston. We get a few in our testing, but we've not really seen them take hold yet. But they clearly have caused a surge there now, but thankfully it looks like it's probably peaked. It's probably too soon to say that with certainty, but it looks like it's probably peaked and at a significantly lower level than what they experienced in the winter. So, if we had to bet, and I've said it many times that, it's pretty much a fool's game to bet around COVID. I would guess that we are having a surge this summer, that we will see more people in the hospital. We will see a lot more people infected. We're already seeing that. I think we're still going to see milder illness, a lower proportion of people getting admitted. So I'm guessing we're going to go up, see a surge, but nothing like, thankfully, we've seen the last 4. And again, I hope my guesses are correct. And of course, as I've always said, if we have a dramatic different variant, bets are off, but thankfully we don't see that right now. So, with that, let's talk about a couple things we all should be doing. This is actually a look now by a not-for-profit foundation that actually looks at affordability of healthcare, but they've specifically looked at some data and some predictive analysis around this. And what this says basically is that almost 250,000 Americans died unnecessarily since the advent of vaccines. So we could have prevented almost 250,000 of the deaths. Said another way, that's well over 60% of the deaths that have happened since the vaccines were available were avoidable. So the human tragedy of this and the human loss is really unfathomable. If you look at this chart, it goes by month. So look at the bottom line of the top chart, and what you see is about, I think it's 22% or so of people are completely unvaccinated in the US. This is adults. So about 78% across the United States have gotten at least 2 doses. And what you see there down at the bottom then is who's dying. Well, the people who are dying are the people in the blue. That is the people who are unvaccinated. Now, it's not 0, obviously, in the vaccinated group. We've talked about many reasons for that in the past, but those are really, really dramatic differences. And if you can then hone in on booster status with the same thing, now what you see is the blue is still the unvaccinated, the green is the people who have not been boosted, and the magenta or whatever that is are the people who have received a booster. So that green plus magenta is the same as the green was on the previous bar. And again here what you see is, again, it's the same level of death in the unvaccinated, but among the vaccinated you're seeing much higher risk of death for the approximately half of the vaccinated people who have not gotten boosted than for the people who have gotten boosted. Again, not 0, but a significant decrease. And again, this is first booster. And now as we see this coming up and you see that going up, you see suggestion of some waning immunity. So if you are pretty much anybody, you should already have gotten a booster. If you haven't gotten a booster, meaning you've only had 2 doses, go get your booster. Obviously, if you're unvaccinated, please go get vaccinated. I know probably we're not going to convince people of that now, but if you've not gotten your booster, go get your booster. We are about to have a surge. You will be at higher risk if you haven't. If you are 4 to 5 months or more past your booster dose and you are 50 and up, or you are at risk, immunocompromised, or otherwise at risk, you should have already now gotten your 4th dose. And if you haven't, I would urge you to go do that as well. Pragmatically, also, I tell my patients, look, you're going to probably get a fall booster. I don't know if it's going to be more variant specific, but you're going to get a fall booster. Get this now because fall is about 5 months away, so the timing is going to sort of be perfect. I got my booster, I don't know, about 6-8 weeks ago now in terms of my 4th dose, and we'll plan obviously on a fall dose. So I would urge you to do those things. And then from the other sort of pivoting, again, not a hard pivot, but start rethinking the really big, all the shackles are off kind of events that we've been to. I've done many of those myself because it was appropriate to do that. And now we're going to have to start rethinking those a little bit, particularly if you're at higher risk. Start thinking about where you're going to be close to people for long periods of time. Flying is still one of those areas that I think is quite safe, but you need to be wearing a mask. You're going to sit with people for, usually minimum 2, sometimes 3, 4, 5 hours, or obviously much longer with the same people, and you don't know what their status is, whether they could be infected, and if you breathe there next door to them, you're going to get it if you do that. A mask can significantly help you, or think about other settings that are going to be similar to that. Now I want to switch just gears and talk about a few other highlights here. We had a wonderful Nurses Week about 2 weeks ago now, and actually had a whole host of nurses that were honored by the Houston Chronicle in their top 150 nurses. And we had 2 of our nurses who were honored in the top 15. Here you see our nursing executive out at Baytown who was one of those 2, Becky Halupa. So we're very proud of Becky and others in our institution, and of course so appreciative to all of our nurses for always, but especially for what they've gone through the last couple of years. And we also celebrated Hospital Week, and this was a lot of fun pictures. We had a selfie station, you can see that in the middle. We had a lot of pet visitation that normally go out to the patients that actually went out to the staff, which I can tell you the pets are always a lot of fun and always really popular. You watch a whole unit light up when these puppies and cats and others show up on their units. And so a great chance to thank our hospital workers, everybody, for the amazing job they do day in, day out, and especially the world they've lived in this last couple of years. Just a couple other key things. Leapfrog is a national group that ranks hospitals based on safety scores, and basically ABCDE or ABCDEF, just like school. And here you see the last decade or so, it's twice a year, and look at the remarkable consistency. I mean, straight A's across the board of our hospital, time and time again. That goes back to our unparalleled safety, quality, service, and innovation, really focusing on the fundamentals and safety first as we do things. Kind of a fun thing we got, again, I always talk about we'll focus on the fundamentals, the awards will follow. But one of the ways you have really great patient care is you have to have really great people. You've seen 3 here in the room with me today, but really across all walks of life, all job classes, all people at Houston Methodist. Well, many of you are familiar with Glassdoor. You don't apply to them, you don't submit data to them, they do all their work there. We were actually ranked by them as number 48 best places to work in the entire country. Of everybody in the country, there were only 4 health systems ranked. We were the highest health system ranked. I think we're right next to Meta, so from Google. So that's kind of cool. So we're just excited about that. Always focused on how we make this a place that's really sticky, that people want to work for. And that's been a challenge, obviously, as we've gone through very, very difficult times in healthcare. And with that, I'll wrap things up, and I want to thank everybody, as always, for your tremendous support. Again, I want to thank our guests here, Drs. Antosh, Bohart, and Rohr, for really great talks today and really great Q&A. So thank you very much. I want to thank Dr. Castile, who I'm sure his fingers are going to need therapy after this, because every time we have somebody in the live stream, they are typing away. And I want to thank Marcy Margolis, who's co-chair of our Women's Health Task Force, and all the members of that task force. If you'd like to be involved in that, let us know. We'd love to get more people involved. We'll be back next month. It's going to be a hair earlier, and it's going to be on a Friday instead of a Thursday. It'll be the 17th of June. We're actually going to talk about how to have a safe summer. So some of the specifics of summer, whether it's skin care, whether it's avoiding insect bites and allergies and other things that happen, accidents that happen in summer. So we'll have some experts from our faculty here who will talk about each of those areas, and I look forward to seeing each of you then. Until then, stay safe and God bless. Thank you.